Hello everyone, this is Dr. Humanist again. Let us now discuss about Huntington's disease or Huntington's chorea. As we know, it's a progressive neurodegenerative disorder characterized by choreiform movements like these are involuntary irregular jerky movements, cognitive decline will be there, and psychiatric disturbances. So we'll see what are those symptoms. Coming to the etiology, it follows autosomal dominant inheritance due to expansion of CAG trinucleotide repeats. Okay, in STT gene in which is present in the chromosome number 4. So this gene encodes for the protein huntingtin. So normally there will be repeats up to 10 to 35, but with this individuals with Huntington disease these repeats will be more than or equal to 36 times. Higher the number of repeats, early the onset and more severe disease will be there. Okay, so because of this mutation, no, there is abnormal version of Huntington protein accumulating in the neurons. Okay, leading to neuronal dysfunction and death, particularly in basal ganglia and cerebral cortex. Okay, pathophysiology, as I said, neurodegeneration because of the accumulation of the abnormal Huntington protein. Okay, so caudate and putamen are affected and cerebral cortex is affected, which leads to atrophy. Okay, and also there is a disruption of the normal balance of neurotransmitters like GABA, dopamine, and glutamate. Next is chorea. As the basal ganglia is gone now, there is a disinhibition of motor pathways resulting in hallmark chorea of Huntington's disease. Okay, so even the degeneration progresses over time, it affects the other parts also, leading to cognitive decline and psychiatric symptoms. Neuronal dysfunction is because of selective loss of GABAergic inhibitory neurons in the striatum, leading to the imbalance in excitatory and inhibitory pathways of the basal ganglia. Okay, this is like overall main is because of that abnormal protein accumulation in the neurons affecting it. Okay, next is clinical features. We'll see motor, cognitive, and psychiatric. What are the symptoms? So typically it will present 30 to 50 years of age, but sometimes juvenile like before 20 or late onset are also seen. Juvenile forms are more dangerous. Okay, it have bad prognosis. So coming to the motor symptoms, first is chorea. Chorea is nothing but rapid, involuntary, irregular movements that can affect any part of the body. Okay, initially they might present with restlessness but progress to more pronounced movements affecting the gait, posture, and the facial expressions also. Next is dystonia, that is abnormal muscle tone. They'll be having like twitching or abnormal postures like movements. Okay, often it will exist with chorea. Next is bradykinesia, that will come in later stages, that is slowness of movement resembling which happens in the Parkinsonism. Next is dysarthria, that is difficult to speak because of the incoordination, impaired coordination of speech muscle. Next is dysphagia, difficulty in swallowing. Because of this, they are prone to have respiratory aspiration pneumonitis and all. That is the one of the causes of death in the cases of Huntington's disease. Next is cognitive symptoms. There will be executive dysfunction. Okay, difficulty in planning, organizing, multitasking, and decision making. Memory decline, working memory and recall memory will be impaired. Dementia, eventually, this global cognitive decline will progress to dementia, which is characterized by impaired reasoning, judgment, and comprehension. Coming to the psychiatric symptoms, usually they'll present with depression. Okay, like high suicide risk will be there in these patients. Irritability and aggression will be there, and obsessive compulsive behaviors like repeat thoughts and actions even can lead to psychosis like hallucinations or delusions will be there. Coming to the diagnosis, clinical diagnosis is very important here because it is autosomal dominant, so 50% cases will be affected, right? So there is a strong family history of Huntington's disease we have to ask. Then second is motor signs, the presence of choreiform movements. Okay, and other motor abnormalities, it raises the suspicions of this disease. Next is cognitive and psychiatric evaluation should be done. Now coming to the genetic testing, that is CAG repeat expansion. This is the definitive diagnosis. Okay, to see these expansions in the STT gene, that is Huntington protein gene. Okay, and the as I said, repeats more than 36 should be considered to have the disease. Prenatal testing, prenatal diagnosis used through amniocentesis or chorionic villa sampling if there is a family history. right? Coming to the MRI, imaging, MRI CT scan will show only atrophy in caudate nucleus and putamen and generalized cerebral atrophy. If you do PET scan or SPECT scan, it will show early functional changes in basal ganglia before the atrophy comes, so early functional changes will be seen. Now coming to the management, so there is no cure for Huntington's disease. Management is symptomatic. Okay, we have to focus on improving the quality of life, managing all the motor, psychiatric, and cognitive symptoms. So coming to the chorea, for that we are using tetrabenazine. It is a vesicular monoamine transporter inhibitor, VMAT2 inhibitor. Okay, so it will reduce the chorea by depleting the dopamine levels. Okay, the side effects can be depression and sedation. Deuterabenazine, it is same drug like tetrabenazine. Next is antipsychotics, risperidone or olanzapine, that is atypical antipsychotics, because there is psychotic symptoms like agitations will be there, so we have to use this. In later stages, as there is a bradykinesia develops, so levodopa can be sometimes be used. Psychotic symptoms like depression is there, so antidepressant like SSRIs, fluoxetine, sertraline can be used. Antipsychotics, okay, for managing psychosis, irritability, and aggressive behaviors. Mood stabilizers like valproic acid. Okay, non-pharmacological treatment like physical therapy, speech therapy, occupational therapy, and psychological support like cognitive behavioral therapy. Okay, coming to the prognosis, it's invariably leads to death. As we know, there is no cure, typically 15 to 20 years after the onset of the symptoms. And but the juvenile form is more dangerous. It will fatal within 10 years of onset. Okay, the patient usually die with the complications of aspiration, pneumonia, heart failure, or infections. So genetic counseling is very much necessary here because it follows autosomal dominant inheritance, and there is a 50% chance of inheriting the mutated gene. Okay, so it is very essential for affected families and prenatal testing or pre-implantation of genetic diagnosis. Okay, coming to the what are the recent advances. So gene silencing therapies have been tried a lot, so like antisense oligonucleotides aimed at reducing the mutant huntington protein expressions are been done. Next is CRISPR Cas9, that is gene editing tools are been studied to modify the HTT gene to reduce the toxic effects of it. Thank you.